Am I clearly visible, audible? Give me a thumbs up in the chat box if I'm clearly visible, audible to you people, so I can go ahead. Thank you. Thanks for confirmation. So I welcome you all for today's session. Very good afternoon to all of you. I am Dr. Priyanka Sachdev here, NEET PG educator on Unacademy, and today I am here to continue my series IBQ 100. So yesterday we have started this series in which I am going to discuss IBQs of complete pathology. So we have already completed hematology yesterday. Hematology, all image-based questions are already done yesterday. So those who have missed, they can watch. Yesterday, 3 episodes were there. Today is the 4th and last episode. So in the first and second episode, I have covered hematology, all anemias, all leukemias, all RBC infusions, RBC shapes, everything from hematology, all possible image-based questions are already covered. So those who have missed it can watch the recording. After that, we have started systemic pathology. In systemic pathology, yesterday we have covered few systems. We have covered CVS, we have covered blood vessels, we have covered GIT. We were on renal system. Renal system was also completed. So from a few questions from renal are still remaining, IBQ. So I will jump on it. And after that, I will move on other systems. And after that, I will move on general pathology, IBQs. Give me a thumbs up. Give me a thumbs up. Should I proceed ahead with this plan? Okay. Just a minute. Let me jump on the last question of yesterday. You have to give me a minute. Okay. So here is the next IBQ. You have to read the question, then answer me. See, this is the image. You can see this is the MRI image. As I have told you yesterday also, most of the IBQs either on gross or on morphology, microbiology, microscopy, or on radiology. So this is on radiology based IBQ. It is MRI shown here. So a 9-year-old boy having recurrent pyelonephritis, no other complaint. He is otherwise healthy. He is having recurrent infection, recurrent pyelonephritis. So MRI is done. This is the MRI. So what is your diagnosis? What is the embryology of this diagnosis of your pathology? And why? Explain why he is having recurrent pyelonephritis. Can you see the image? Let me zoom the image for you people. Okay, see this image. Who will tell me what is the pathology here? Why the person, why the boy, young boy is having recurrent pyelonephritis? Who will tell me why it is having? Who will tell me why? Why the person is having recurrent pyelonephritis? Anyone among you from the audience? You see MRI, it is very simple. It is a spot diagnosis. It is very easy. Most of the easiest MRI that can come in your exams. See the MRI, it is clear. Okay, there is a red mark. I will give you a clue. There is a red mark. See the red mark. What it is showing? What is this structure? Okay, let me mark the structure. One more clue. Then you write your answer in the chat box. It is not MCQ. Write your answer in the chat box. What is this structure showing? What is this structure? It is marked by the red color, red dot. What is this structure? Karthik is absolutely right. Anyone else from the other than Karthik want to give it a try? Yes, these are the 2 kidneys which are fused at the center. So looking like a horseshoe shaped kidney. So yes, it is horseshoe shaped kidney. So it is an incidental finding. It is incidental finding. Only complaint in the boy was recurrent pyelonephritis. So many people have horseshoe-shaped kidney, but it is asymptomatic. It is asymptomatic, so it is not diagnosed. So here in a child, since he was having recurrent infection in the kidney, recurrent pyelonephritis, so otherwise he is absolutely healthy. His urine analysis was healthy. All other things were healthy. He was not having fever or something else. So MRI is performed. We see this abnormality in the MRI. So it is typically showing. Can you see? Can you see this structure? It is horseshoe-shaped kidney. The 2 kidneys are fused at the center. It is horseshoe-shaped kidney. It is a spotter, huh? It can anytime come in your exams as a IBQ. In IBQ, the examiner try to give you that image that will be a spotter. That will be a spot diagnosis. Means looking at the image, तुम्हें ज़्यादा दिमाग नहीं use करना पड़े. Looking at the image, the diagnosis is straightforward. Such image will come in your exam. So it is one of them, I guess. No other alternate diagnosis. It is typical horseshoe-shaped kidney. So the diagnosis is horseshoe-shaped kidney. So this is a simple question. Identify the diagnosis. If I want to increase the difficulty level of this question, I will not ask what is the diagnosis. I will give you the image. If I am the examiner, I will give you the image and I will ask you what is the embryology of your diagnosis. First, make the diagnosis. It is a 2-step question. First, make diagnosis, then tell me the embryology of that. So you should know 2 things. First, diagnosis is clear. So it is horseshoe-shaped kidney. So why horseshoe-shaped kidney occurs? You know, this is horseshoe-shaped kidney. Can you see? The 2 kidneys are fused here. The 2 kidneys are fused here. So it is a horseshoe-shaped kidney. The 2 kidneys are connected, are fused at the lower pole. So what is the embryology? Metanephros normally remains separate, but here fusion occurs in 1 in 500 individuals. So every 500, one person is having this, but usually it is asymptomatic. But why our boy is having pyelonephritis? Explain the symptoms. Why this boy is having pyelonephritis at all? So see, this is horseshoe-shaped kidney gross. You can see this is the anterior view, this is the posterior view. The two kidneys are connected. The two kidneys are connected here, and you can see a course of the ureter. Can you see? This is the ureter. This is the ureter. Can you see? Ureter is twisted. So sometimes due to twisting, due to this shape, the ureter is twisted, having a twisted course. So there is obstruction at the ureter. Because of the obstruction, there is recurrent infection. Give me a thumbs up. Do you know the cause of recurrent infection now? It is abnormal ureter course. That is due to twisting. Due to twisting, there is some degree of obstruction, and that obstruction leads to recurrent infection. Partial obstruction, that is leading to recurrent infection. So any question on this image you can answer now. You can give the diagnosis. It is a spotter. It is a diagnosis. It is the most easy question. You can know you should know the embryology of this diagnosis, and you should know why the person will have recurrent pyelonephritis. Let me move on to another image-based question. So now I will give you some image-based questions, important ones, spotters from breast. So this is the question. The image is in front of you. Typical image, spotter. Without reading question, you should tell me the answer. It is a spotter. So what you are seeing? You are seeing a 31-year-old sister of a patient on slide A has mammogram that reveals a suspicious density. The biopsy specimen had microscopic appearance as shown here. Another sister was diagnosed of having ovarian cancer. So there are two sisters. One of the sister is having breast mass, and another sister is having ovarian cancer last year. So this is the histology image given to you from the breast. Look at the image and tell me the diagnosis, and tell me the mutation for this diagnosis. So two questions I am asking. First, tell me the diagnosis. Try to tell me the diagnosis. Look at the image. Try to tell me the diagnosis. Once you reach the diagnosis, telling mutation of it is very easy. Now, there is a clue in the question. Another sister is having ovarian cancer. So breast and ovarian cancers are related to some gene. So it will help you to reach the diagnosis. So what is the mutation? What is the diagnosis, by the way? Okay. So let me zoom the image and tell you what is the diagnosis here. Can you see this is the image from breast mass? Now the mass can be benign, can be malignant. But here the mass is malignant. Why I am confident the mass is malignant? I can see tumor cells are arranged in glandular fashion. Tumor cells are arranged in cords. These are the cords. Tumor cells are arranged individually also. Individually single cell in the stroma of the breast. The background is the pink colored stroma of the breast. And all of these cells are tumor cells. See, all of these cells have hyperchromatic nuclei, high ANSI ratio, hyperchromatic nuclei, and haphazard arrangement. So it is not normal breast. It is a cancerous breast. So the patient is having breast cancer. The diagnosis is breast cancer. Which type of breast cancer? There are two types, ductal and lobular. Invasive ductal, IDC, or invasive lobular. It is invasive ductal type. It is not invasive lobular type. In invasive lobular type, you have typical one feature which is known as Indian file pattern, in which tumor cells are arranged in a train, one behind the other, like this only. They are not arranged in glandular form. Here I can see tumor cells arranged in glandular forms also. So it is not ILC, it is IDC. So my diagnosis is invasive ductal carcinoma of breast. So at your level, you are an MBBS student now. At your level, saying only breast cancer doesn't suffice. So looking at the image, you should first make a diagnosis. Yes, it is a breast mass, number one. It is a breast mass. And if it is a breast mass, it is a malignant, because you can see the haphazard arrangement of the cells. You can see hyperchromatic nuclei. You can see high ANSI ratio. So it is breast cancer. So classify it. Which type of breast cancer? So of course, it is invasive ductal carcinoma. So name the mutation. For mutation, there is a clue. There are two sisters. One is having breast cancer, other is having ovarian cancer. So tell me a common gene. Write it down in the chat box. Now, tell me a common gene which is responsible for the two cancers, breast and ovarian. Both the sisters have that gene mutated. No, Kushi, it is not P53. It's very easy. The common gene for breast and ovarian cancer. Yes, anyone? Yes, Vikram, you are right. Yes, Rahul, you are also right. Yes, Dr. Tariq, you are also. It is BRCA. It is BRCA1. Very good. So what is the diagnosis? It is IDC. You can see the background stroma is more pink. It is collagenous stroma. And in the collagenous stroma, we can see irregular cords of the cells. So that is the tumor, and the gene mutated is BRCA, which is responsible for ovarian cancer as well as breast cancer in females. If BRCA is mutated in females, it results in breast and ovarian cancer. If BRCA is mutated in male, it results in which cancer? Another question to you. Same scenario, another question to you. So BRCA is mutated in male. If it is mutated in male, it will result in which cancer in male? In male, there is no ovary, there is no breast. Breast is rudimentary. So yes, Meghna, you are right. So yes, no Rahul, it is not myo. It is prostate. So BRCA, so this is the summary, BRCA1 gene, BRCA1 gene. So if it is mutated in females, it results in breast and ovarian cancer. If it is mutated in males, it results in prostate cancer. Please learn it. That is the thing. Have you got it? This is the next image-based IBQ in front of you from breast. So see, there is some pathology here marked by this black dot. Can you see this pathology here? This pathology here. Can you see? What is the pathology? So see, read the question. A 71-year-old female. So she's an old female. Age is always a clue. She's an old female having 5-month history of rough, scaly skin over the left breast. We can see this is rough, scaly skin over a area over the breast. On examination, there is underlying ill-defined 5 centimeter mass below this. So on examination, on palpation, there is a 5 centimeter mass below the skin, and she is ER negative, PR negative, but HER2 positive. So 3 hints are given in the question: ER negative, PR negative, but HER2 positive, ER/PR negative. So what questions they have asked to you? What is this typical skin appearance known? It is a classical finding. Skin appearance in a breast cancer. Can you see? Can you name one skin appearance for this? One word for this. Typical appearance of the skin. Puckering. No, Rahul, it is puckering. I agree. But that classical word I want to hear. What treatment options you will offer depending on the molecular analysis? She is ER negative, she is PR negative, and she is HER2 positive. So what treatment offer you will offer to such female? What targeted therapy you will offer? So this is known as PDO orange. Can you see orange color skin? This is known as, yes Rahul, it is known as PDO orange because the skin is orange color. Can you see? This skin appearance is looking like a orange. So typically in breast cancer, so this is a breast, this is the nipple, this is the tumor inside the breast. If there is some tumor inside the breast, so skin just above the tumor become orange color, it becomes puckered, it becomes hard, it becomes scaly. So this skin is known as PDO orange. It is representing an underlying malignancy. So the term here is PDO orange. PDO orange. Have you got it? So there is, why PDO orange? The skin is becoming this orange color skin here. Why? What is the reason of this orange color skin here? Orange color skin क्यों हो जाता है? What is the reason? Because there is underlying malignancy now. That malignancy, that tumor is obstructing the lymphatics, and lymph has got collected here. Because of lymphatic obstruction, the skin got edematous, it got puckered, it is looking an orange color, it is looking granular like the skin of orange. This is a fruit now, orange fruit you all have seen. So the skin of the orange is granular. So skin is also same way, it is granular and reddish in color. Not orange, it is reddish. Reddish in color. Radish is there, edema is there, granularity is there. It is looking appearance of an orange due to the obstruction of the lymphatic invasion. Give me a thumbs up. That is the thing. Now come on the second question. What treatment you will offer to such female? So she is ER negative, PR negative, HER2 positive. This question is based on molecular classification of the breast cancer. You should know molecular classification of breast cancer. There are 4 types of breast cancer: luminal A, luminal B, basal, and HER2 positive. This is molecular classification. It is trending. Many questions are coming from this classification. Nowadays, we use this classification. So first, you are a surgeon. If any female is coming to you with breast cancer, what you have to do, you have to operate her. You have to take the tumor out, send this tumor to pathology, to the lab. The pathologist will tell you whether she is ER/PR positive or negative, whether she is HER2 positive and negative. So 4 possibilities are there. From the lab, report can come, she is ER/PR positive but HER2 negative. She is ER/PR positive, also HER2 positive. She is all negative. ER also negative, PR also negative, HER2 also negative. It is known as triple negative because all 3 things are negative. Triple negative breast cancer, TNBC. It is known as TNBC, or ER/PR negative or HER2 positive. So 4 possibilities are there. So let me talk about one possibility. If she is ER/PR positive and HER2 negative, it is known as luminal type A, and you will offer only hormonal therapy to her. You will offer tamoxifen to her. Tamoxifen will be given because she is ER/PR positive, and tamoxifen is ER/PR blocker. She is HER2 negative, so don't offer Herceptin to her. Herceptin is HER2 blocker. So HER2 to hai nahi, so why you want to block it? So don't offer Herceptin to her. So you can offer tamoxifen to her and not Herceptin. To the first patient, luminal A. Luminal B, you will offer tamoxifen also, Herceptin also, because she is all positive. Triple negative, you can't offer any treatment. You can offer only chemotherapy. No targeted therapy, no hormonal therapy. And in HER2 positive, only Herceptin is given, tamoxifen is not given. Now read our question. What is our question? In our question, the female is ER/PR negative and HER2 positive. So she is the last category. That is HER2 positive. So she is ER/PR negative. We can't offer tamoxifen to her. We can offer Herceptin to her. Another name of Herceptin is trastuzumab. So that is the thing. So that is the answer. You can see here. Just a second. I'm sorry. You can see here. This is the answer. So you cannot offer tamoxifen, but you can offer trastuzumab because she is ER/PR negative. So tamoxifen is ER/PR blocker. You can't offer it because it is negative. And tamoxifen, your trastuzumab, that is Herceptin, you can give. It is HER2 blocker. Give me a thumbs up. Give me a thumbs up. This is the next question. Spotter, breast lesion. Breast lesion, 30-year female breast lesion. The diagnosis. Two images are given. This is low power, this is high power. Same lesion. इसी को मैं zoom करूंगी तो ऐसा दिख रहा है. Low power and high power. Same image. Breast lesion. 30-year female. Diagnosis. It is a spotter. Looking at the images, Vikram, you are right. Anyone else apart from Vikram want to answer? Diagnosis. Breast lesion. Diagnosis. So yes, it is a benign breast lesion. It is known as fibroadenoma. You all can see it is the image of fibroadenoma. So what you can see in the normal breast, it is typically fibroadenoma of the breast. Very important IBQ for your exams because it is a typical spotter now. As I have told you, in IBQ questions will come which are typical spotter, जो complicated होगी, that will not come in your exam. Typical spotter will come. So it is a typical spotter. What you can see, background stroma is too much. See the first image, background stroma is too much. Actually, this is a breast. How normal breast looks like? This is normal breast. In normal breast, you find two components. Background is stroma. Can you see the background? The background is stroma. Let me mark the background. This is all background. This is all stroma. Background is all stroma. And apart from it, you can find epithelial component. Epithelial component is glands, circular glands. Normally, there is a proportion between the stroma and the epithelial component. Stromal and epithelial component ratio is known as. This is known as. But in fibroadenoma, stroma increases too much and it compresses the glands. So glands will become compressed. So this is stroma in the background. It will increase too much. Circular gland will be compressed. It will collapse and it will become like this. So all the glands will become slit-like because of compression. This is known as slit-like arrangement of the glands. Give me a thumbs up. So see the first diagram. All the glands, they got compressed. They become slit-like. See here, see here, see here, because the background stroma is compressing it. Have you got it? Have you got it? So this is normal and this is fibroadenoma. So look at your image. Look at your image. So can you see this is a gland which is compressed. This is a gland. This is a gland which is all compressed. This is a gland. This is a gland. All the glands are compressed. And see the background stroma. See the background stroma. It is hyperproliferative and it is compressing all the glands. It is hyperproliferative. It is compressing. See here also all the glands are compressed. Can you see a lumen in the glands? A small lumen. This is one gland. A small lumen inside it. This is another gland, small lumen. So all the glands are compressed, they become slit-like. Give me a thumbs up. So it is a typical image of fibroadenoma, which is a benign breast lesion, which is the most common tumor in the breast. It is a benign tumor. So stroma becomes highly cellular. It becomes fibrous and it compresses the ducts and the glands. So ducts and glands will become slit-like. They will become slit-like. Can you see here? Slit-like, compressed duct. So that is a hallmark of fibroadenoma. Now I will give you a few IBQs from CNS. Very important, CNS. So the first IBQ in front of you. Typical image. Young boy, child is there. 4-year-old child is there. Having headache and ataxia. So boy was having vertigo. Boy was having severe headache. He was a young child. Young boy, he's a child. 4-year-old child. We have done an MRI. On MRI, we find a cystic tumor in the cerebellum. Now, location of the tumor in brain is very typical. It is in cerebellum, not in cerebrum. It is in cerebellum. So, child में, cerebellum में, कौन सा tumor होता है? In a child, in cerebellum, which tumor is most common? Histologically, the tumor is composed of, the image is given to you. It is composed of elongated, fibrillated cells and with Rosenthal fibers. Can you see the pink color fibers here? I'm marking for you. This one, the pink color fibers. These are known as Rosenthal fibers. And BRAF mutation is there. Molecular analysis is showing BRAF mutation. Name the tumor. Which tumor is it? Name the tumor. So mark your answer in the form of the poll. I have launched the poll. Please mark your answer. Everyone. What it is? Is it schwannoma? Is it medulloblastoma? Is it pilocytic astrocytoma? Is it ependymoma? So schwannoma and ependymoma do not occur in children, and if they occur also, the location is not cerebellum. So pilocytic astrocytoma and medulloblastoma occur in children, but medulloblastoma may, there is small cell tumor. It is a small round blue cell tumor. So it is not medulloblastoma also. It is pilocytic astrocytoma. So yes, most of you are right. The correct answer here is C. Nimisha, Manush, Kiran and Karthik are first to answer it correctly. Correct answer here is pilocytic astrocytoma. It occurs in children. It occurs in cerebellum. BRAF mutation occurs and Rosenthal fibers are there. So 4 clues, all 4 are fitting in the image. So in the image, we can see Rosenthal fibers. So I will explain you the CNS tumors. Now CNS, in the brain we have 2 types of tumors: primary, which originate in brain only, and metastatic, which are coming from other locations, that are known as metastatic. Metastatic are more common as compared to primary. Let me talk about primary brain tumors. Primary brain tumors, metastasis most commonly come from lung. Most commonly metastasis comes from lung followed by breast, but this is a PYQ. Most common metastasis in brain comes from which organ? It is from lung cancer. So it is a PYQ. It is a PYQ. Please learn. You may have seen this PYQ in your pathology. I have discussed PYQs last Wednesday. So this question was there, if you remember. Done. So lung followed by breast, followed by skin melanoma, followed by kidney. So these are the tumors which send their metastasis to brain. Let me talk about the primary tumors. These are the primary tumors in the brain. I will not teach you all. The most important are gliomas, which arises from neuroglia. Gliomas are the most common tumors in the brain. Gliomas are of 3 types: astrocytoma, oligodendroglioma, ependymoma. Those arise from astrocytes are known as astrocytoma. Arise from oligodendrocytes are known as oligodendroma. And ependymoma, which arises from ependyma. That is the 3 types. Astrocytoma again are of 4 types. So WHO grade 1, 2, 3, 4. Grade 1 is known as pilocytic astrocytoma. Grade 2 is known as fibrillary astrocytoma. Grade 3 is known as anaplastic astrocytoma. And grade 4 is known as GBM, glioblastoma multiforme, GBM. That is grade 4. Most important, the grade 1 occurs only in children. Grade 4 occurs only in adults. Grade 1 is having good prognosis. Grade 4 having very poor aggressive prognosis. Grade 1 occurs in cerebellum. Grade 4 occurs in cerebrum. Now you tell me which is fitting in our scenario. Our question, the child was there, 4-year-old child, and having a tumor in the cerebellum. The image microscopy of all of them is different. Now there is no time I can show you the microscopy of all of them, but it will take time. So I'm teaching you microscopy only of the first one, which is typical pilocytic astrocytoma. In adults, there is GBM, which is poor prognosis. In children, it is pilocytic astrocytoma grade 1, which is good prognosis. This is grade 4, this is grade 1. And in between, इसके अलावा 2 grades और होते हैं. So in pilocytic astrocytoma, Rosenthal fibers are there. You know, these are the Rosenthal fibers. Can you see the pink color fibers? Pink color fibers in a fibrillary background. This is normal background. These are Rosenthal fibers. What are Rosenthal fibers? Next question. What are Rosenthal fibers? Why they are formed in pilocytic astrocytoma in children in brain? It is a cystic tumor. So Rosenthal fibers are condensed mass of a protein known as GFAP. That is glial fibrillary acidic protein. It got condensed. So multiple condensed form of GFAP is forming this pink mass. So Rosenthal fibers. So questions can come on this. This year NEET PG question was on composition of Mallory-Dank body. So next year maybe composition of Rosenthal fiber. What is Rosenthal fiber made up of? It is made up of GFAP. It is a protein. Give me a thumbs up. Give me a thumbs up. That is pilocytic astrocytoma. Done. Have you got it? This is the next question in front of you. So which of the following best fit for the image given below? It is a brain tumor. It is a brain tumor spotter. Brain tumor spotter. Okay, I will give you the clue. I will give you the clue. What you can see in this image? I can see some blue color central masses. Blue color. Deep blue color central masses are there. Deep blue color central masses are there. Apart from it, I can see the tumor cells. Tumor cells are arranged in balls. Around these masses, tumor cells are arranged in balls. Now tell me the typical diagnosis. Typical diagnosis. Write down in the chat box. What is the typical diagnosis? Is it a meningioma? Is it a schwannoma? Is it a hemangiopericytoma? Is it a glycosarcoma? What it is? Who will tell me what it is? What it is? Yes? What is the diagnosis here? Anyone? Write down in the chat box. Now at least have a guess. ABCD. Okay, let me launch a poll then. Okay, most of you are right. The correct answer here is meningioma. Okay, so Vikram, Meghna and Lost Doctor. Lost Doctor, no, you are saying schwannoma. No, it is not schwannoma. Schwannoma means central. These circles kya hai? The blue color circles. Meghna, what are these central blue color circles? Meghna is saying D. No, it is not gliosarcoma. Only Vikram is right. It is meningioma. Central blue color circles, these are psammoma bodies. That is calcification. That is the hallmark of meningioma. So meningioma is there. So in meningioma, it arises, it is a tumor of meninges. So this is a brain. In brain, we have three meninges. The innermost meninges is pia meter. This is pia meter, covering the whole brain. The middle one is arachnoid, and the outermost one is dura meter. So meningioma is a tumor of meninges, mainly arachnoid layer. So it arises from arachnoid. कौन सी meninges का tumor है? कौन सी meninges का? It arises from the arachnoid layer. It arises from the arachnoid layer. Learn that, from the arachnoid layer. It is solitary. Always it is single. So you can see it is always benign. Usually, sometimes, rarely it got converted into malignant. Otherwise, it is benign. You can see this is the most common location of meningioma. It is arising from meninges, meningioma. So this is the typical microscopy. This is the typical microscopy. What you can see only two things. Number one, blue colored masses in the form of central pearls. These are calcification. It is calcification. It is known as psammoma bodies. P is silent. Psammoma bodies is calcification. Calcification. Around this calcification, tumor cells are arranged in the form of the whorls. Tumor cells are arranged in the form of the whorls around this calcification, and tumor cells are spindle shaped. These are not circular. All tumor cells are spindle shaped. So only 2-3 findings are there. Please learn it. It is a typical diagram of meningioma. Meningioma is a spotter. So brain tumors तो बहुत सारे हैं, लेकिन उनमें से स्पॉटर कितने हैं आईबीक्यू के लिए? So this is a spotter. Last रोजेंथल फाइबर वाला भी स्पॉटर है. So एकदम से स्पॉटर वाली जितनी भी इमेजेस हैं, it should be at the tip of your tongue. You should identify. Looking at the image without reading the question, you should say it is the image of meningioma, ma'am. It is the image of, I can see rosenthal fiber. Oh, it is the image of pilocytic astrocytoma. So looking at the image, these images are spotter. You know, breast में fibroadenoma image आते से you should identify it as fibroadenoma. IDC image आते से it is IDC. So looking at the image, spotter, image is spotter. You should know the diagnosis. You should know the diagnosis. If you wish, I can share you a PDF of all images, nearly 500 images in entire pathology. That is general, hemat, and systemic, all systems from Robbins. All images are from Robbins. So only PDF contains image, its diagnosis. Image, its diagnosis, no description. So you should learn the image, that this is the diagnosis, and why it is there. The labeling should be there. Why it is there? Why? Because it is rosenthal fiber. That's why it is pilocytic astrocytoma. Because it is having psammoma bodies. That's why it is meningioma. So all images have some hallmark in it. Some hallmark in it. So identifying that hallmark with labeling, you should make the diagnosis. Give me a thumbs up if you got it. So that is the way. That is the way you should understand your IBQs. Now your most of the papers is going to be IBQs, especially in FMGE. You have seen the pattern. Nearly 30 to 35% of the paper is going to be IBQ. You are going to get out of 300, nearly 100 will be your IBQ questions. IBQ questions done. So IBQs is really very, very important. You should understand all images. And pathology, now from 19 subjects, it is not the thing that IBQ will come from all the subjects. There are subjects from which IBQs are more common, more prone to come. Anatomy में images are there. तो anatomy से ज़्यादा chances है. Physiology, biology से इतना chance नहीं है IBQ आने का. Pathology, microbiology से ज़्यादा chance है. Pharmacology से ज़्यादा chance नहीं है. IBQ क्या आएगा pharmacology में? So IBQs आने का ज़्यादा chance नहीं है. आ सकता है, but there is not much chance from pharmacology. सर्जरी से, मेडिसिन से, ओबीजी से, these are clinical subjects, इनमें इंस्ट्रूमेंट्स वगैरह आ सकते हैं. ऑप्थेल में आईबीक्यू बहुत आ सकते हैं. So depending on the subject weightage, which subject carries a high chances of coming IBQ, you should understand the IBQs from that subject in that way. Give me a thumbs up if you got it. Should I move to the next question? This is the next question in front of you. So it is based on gross of the brain. You can see a brain. So read the question, you will get the clues from the question. Looking at the image only, you should make the diagnosis. What you are looking, this portion of brain is something different from rest of the portion. So this is occipital lobe. Yes, you can identify it as occipital lobe. And rest of the brain, what it is showing? So there is gyri and sulci. This is known as gyri and this is known as sulci. So gyri and sulci. Sulci, two things are there: elevation, depression. Elevation, depression. The whole brain have gyri and sulci. So in this image, I can see gyri are thinned out and sulci are more deep. In the whole image, gyri are thinned out. They are thin, and see the sulci. They are more deep sulci. Depression is more. So this is known as atrophy of the brain. So brain, the entire brain is showing atrophy except occipital lobe. Occipital lobe is normal. It is not showing atrophy. Give the diagnosis. Vikram, again, you are right. Yes. Give the spotter diagnosis. It is a spotter. It is typically showing the whole brain is showing atrophy except one lobe, occipital lobe. Typical diagnosis. Okay, I will read the question for clues. Question पढ़ने की जरूरत ही नहीं है. Looking at the image only, you can make the diagnosis. What it is showing. I have told you the approach also. Okay. Okay. A 77-old year male is there. So old age is a clue. Having 3-year history of progressive withdrawal apathy. So depression, history of depression, withdrawal and apathy, memory loss, short-term memory loss, dementia. Patient is having depression, dementia, patient is old. He is not oriented of place and time. He is not knowing where I am and what is the time right now. He is not having any orientation. Before further workup, he commits suicide. He was depressed now. He commits suicide. So we have done the autopsy. In autopsy, we take the brain out. This is the brain. What is the diagnosis? Tell me the gene mutation which is responsible for this diagnosis, for that. So 2 questions. Number 1, diagnosis. Number 2, mutation responsible for the diagnosis. So as Vikram is right, it is Alzheimer's disease. In Alzheimer's disease, you see the whole brain. The whole brain. It is marked cortical atrophy with pairing of occipital lobe. In occipital lobe is always paired in Alzheimer. So see, this is occipital lobe, it is paired, and rest of the cortex, this is the cortex now, the cerebral cortex, it is showing atrophy. So it is Alzheimer's disease. So atrophy, can you see the atrophy? Give me a thumbs up. Give me a thumbs up. It is typically Alzheimer's disease. Once the diagnosis is made, question is fun for you. Now you know the genes for Alzheimer's disease, right? So there are 4 genes now for Alzheimer's. Most commonly APP gene, which is present on chromosome 21. It is mutated. Second most common, it is also associated with Down syndrome, that is trisomy 21. Down syndrome वालों को भी Alzheimer's ज़्यादा chance है. Chromosome 19 पे there is another gene which is known as E4 allele that is also mutated, and chromosome 14 and chromosome 1 पे presenilin genes are present. Presenilin 1 and 2, these are also mutated. So make a list of the genes. All these genes can be mutated in Alzheimer's disease. Give me a thumbs up. It is not necessary all genes are mutated in a single person. Different genes, all these genes are responsible for Alzheimer's disease. Mutation of them. So make a list. कौन सा gene? Name the number of chromosome also. So question, if the examiner wants to frame easy question, this is the image. What is the diagnosis? So this is the easy question. If the examiner wants to frame a difficult question, this is the image. Image is same. But question, I'm not asking what is the diagnosis. What is the mutation of this diagnosis? So that will be a 2-step question. So question can be 1 step, 2 step, 3 step. The examiner wants to increase the difficulty, so multiple step question can also be framed with the same image. So that is testing your knowledge. If I ask simply diagnosis, so that will be of 1 step. So most of you, 50% of the audience will be correct. Of course, 50% अभी भी identify नहीं कर पाएगी. Now, एक step मैं और बढ़ा दूंगी. What is the mutation? So सिर्फ 25% will be correct. So that is the thing. So that is how examiners frame question. Now you have to think with the mentality of examiner. Do not think with the mentality of a student. So you will give the exam. How examiner frame the question, you have to prepare yourself in that way. So that only you will crack the exam and score a good rank in your exams, whatever you are targeting. Give me a thumbs up. Have you got it? Have you got it? Okay, this is the next question. Again, based on gross. Again, based on gross of the image, gross of the brain. So can you see this portion? It is marked here with the arrow. This portion of the brain as compared to rest of the brain. Compare it. You will find some difference. You will find some difference. See? Can you see? So I'm drawing a line. Can you make out a line? Yes, you can. This is the line. Now compare this portion and this portion. What is this lobe? This is frontal lobe. This is frontal lobe. Yes or no? This is frontal lobe. So what you can see? I can see atrophy in which lobe? I can see atrophy in which lobe? So of course it is atrophy now. That is narrowing of the gyri and deepening of the sulci. That is the definition of atrophy. जो gyri है, they will become narrow, and sulci will become deep. Gyri narrowing, sulci deepening. That is the definition of atrophy in brain. So I can see atrophy in which lobe? I'm asking to you. Looking at the image, tell me now in which lobe. So yes, Patel, you are right. It is frontal lobe. Meghna, Khushi, okay. So in which disease frontal lobe atrophy takes place? Exclusive frontal lobe atrophy. Exclusive frontal lobe atrophy. Yes, Nimisha, you are also right. So disease is Pick's disease. So without reading the question also, you can pick it. Yeah, so it is Pick's disease. It is Pick's disease. This is frontal lobe atrophy. So if atrophy takes place in the whole cortex, sparing occipital lobe, that was our last image. You can see the occipital lobe is spared and rest of the brain is showing atrophy. So the diagnosis was Alzheimer's disease. Say yes or no, give me a thumbs up. And here in this diagram, you can see atrophy only in frontal lobe. Rest of the brain is normal. It is normal. It is not showing atrophy. So the diagnosis is Pick's disease. It is Pick's disease. Now we will read the question also. 63-year-old, again old man, having 3-year difficulty history of difficulty in activities of daily living. He become irritable, irresponsible, and develops speech difficulties also. She is dead of aspiration pneumonia, brain autopsy. So have you got it? It is Pick's disease. It is Pick's disease. It is Pick's disease. Give me a thumbs up. Now, why the aspiration occurs? Patient is dead of aspiration pneumonia. Why the aspiration occurs? Because of loss of consciousness or altered consciousness. So the portion of the brain which is maintaining consciousness is lost because of atrophy. So patient lost consciousness. Patient can go in coma, and because of which aspiration can always take place. Give me a thumbs up. Give me a thumbs up. Next question in front of you. See, a MRI is given to you. A MRI of brain is given to you. What you can see in the MRI? This is a 47-year-old male MRI having 3-month history of worsening headache, severe headache. That's why, and seizures. So he is having repeated episodes of seizures and he is having headache. We have done an MRI. This is the MRI, typical MRI in front of you, typical MRI. After which he undergoes surgical debulking and radiation and chemo. So what is the diagnosis? Uska treatment bhi ho gaya. What is the diagnosis? Some pathology is shown by the red dot. Yes, Milind, you are right. Some pathology is shown. What normally you can see the cortex here. These are the cerebral cortex. And this is the fox cerebri. You can see the midline structure. Can you see the fox cerebri here? So some tumor is arising from the central portion. This is the tumor. This is the tumor. So it is a tumor in the brain. Which tumor? What is your diagnosis? Looking at the image and location of the tumor, tell me the diagnosis. Yes, Milind, Patel, you are absolutely right. Milind, you are right. Tell me. Not at you are an MBBS student now. Saying only brain tumor, breast tumor. No, it doesn't look nice. You should classify it. Try to classify it, at least. Okay, it is brain tumor. So a kid is also knowing it is a brain tumor. It is looking like a tumor. So at your level, you should be able to identify it, looking at the age of the patient. So in adults, what is the most common brain tumor in cerebral cortex? So the answer is GBM. The answer is GBM. No, it is not Huntington's disease, Karthik. It is not Huntington's disease. It is a big lesion in the cerebral cortex and in an adult brain causing the symptoms of seizure and headache. So it has to be a brain tumor, that is GBM. And for Huntington's, we will not give radio, chemo, and surgery. So we have done surgery, radio, chemo, so it is a mass. We have done the debulking. So that is also a clue given in the question. What is the prognosis? Prognosis is very poor. I have told you now 4 WHO grades. Grade 1, grade 2, grade 3, and grade 4. There are 4 types of astrocytoma. So the first one is known as pilocytic astrocytoma. Second is fibrillary astrocytoma. Third is anaplastic astrocytoma. Fourth is glioblastoma multiforme GBM. The first exclusively occurs in children. The first question was on that. And it shows Rosenthal fibers in that. The first question we have already seen what is Rosenthal fiber in one of the image. Yes, that was the first question today, right? And it is having very good prognosis. The last one occurs in adults. It arises from cerebrum. This was arising from cerebellum. Children वाला cerebellum में होता है, adults का cerebrum में होता है, cerebral cortex, and it is having very poor prognosis. It is grade 4, so it is GBM. Done. It is GBM. Can you see? It is GBM. It is GBM. So very few patients survive more than 1 year. Most of the patients die within 1 year. It is having very poor prognosis. It is very aggressive. Give me a thumbs up. Give me a thumbs up. Diagnosis: spotter, brain, image of the brain. Diagnosis: spotter. It is a spotter, no history. Looking at the image only, it is a spotter. It is a spotter. What you are seeing some spaces in the brain, vacuolated spaces in the brain. Can you see the vacuolated spaces? So brain is okay. Should I give the clue? Should I give the clue? Or you will be, apart from it, you can see the pink color neurons are there. The neurons are normal, but what are these spaces? What is the diagnosis? It is a spotter. I'm teaching you spotters only because spotters are going to come in your IBQs. You should know. Looking at the image, you should know the diagnosis. I will tell you only the organ. Clue. Vikram is asking for clue. Vikram, I have given the clue. There are spaces. You can see the spaces here. The empty spaces are there in the brain. Small, multiple empty vacuolating spaces. Okay, one other clue. The brain is looking like a sponge because of empty spaces. Brain is looking like a sponge. Ab to bata do. Ab to bata do, Hansar. I have given the clues also. Yes, brain is looking like a sponge. So it is spongiform encephalopathy. Spongiform encephalopathy, also known as CJD. So in CJD, histologically, there are small holes in the whole brain. Small empty holes. Can you see the white color? Let me zoom it out. The white color, small empty holes in whole brain. Can you see? This is not normal. This is not the pink color, not the neurons. I agree. What is there in between the neurons? It is small pink color holes, small air containing holes. So brain is looking like a sponge. That's why known as spongiform encephalopathy. The other name of spongiform encephalopathy occurs in animals also. In humans, it is known as CJD. And if you ask me a clinical question, I will give you like this: a 47-year-old male with progressive dementia. 47-year-old male, any age I can give, middle-aged male having progressive severe dementia. And he's dead and brain autopsy, this is the finding. So that was the question. That was the question contains only one clue, it is dementia. So it will present with dementia. So the clue was there in the image. Clue was there in the image. Second question based on same image. I will give you the image. First question I can ask diagnosis. That is a level 1 question. Diagnosis, easy question. The answer is spongiform encephalopathy, also known as CJD. CJD in humans. My second question, what is the pathology of this disease? Look at the image. Identify the pathology. Identify the diagnosis. What is the pathogenesis of this diagnosis? Pathogenesis. One word pathogenesis. Why CJD occurs? One word pathogenesis. Don't tell me the whole process. Yes, Vikram, prion. So it is a prion disease. You know what are prions? You know what are prions? You know? Yes or no? So you know what are viruses? Viruses have two things compulsorily. One is nucleic acid, which is either DNA or RNA, but never both. And number two is protein covering, which is known as capsid. So the two things, if always present. Now envelope, some viruses have envelope, some do not have envelope. Envelope is not compulsory, but the two things are compulsory. That is nucleocapsid. Nucleic acid and capsid together known as nucleocapsid. Now this is a complete virus. There are some viruses who have only capsid, who do not have nucleic acid inside them. Empty capsid is there. It is a protein covering only protein covering. Such viruses are known as prions, made up of protein, only protein, no nucleic acid. They are prion. Or if nucleic acid is present, we humans are unable to identify it yet. So we can see only protein. So such viruses are known as prions. Yes, Milan. Cow mat disease is also there, but it is animal. Cow में होगी वो, humans में नहीं होगी. So cow में CJD is known as cow mat disease. You can see, you can say like this. So this is CJD number 1, spongiform encephalopathy, CJD, and it is occurring due to prion. Prion. So this image I can put as a small spotter in your exams. Give me a thumbs up. Give me a thumbs up. Next question. Again a spotter. Again a spotter. Two sections are shown. This is cerebral cortex. You can see the two cerebral cortex, and this is cerebellum, the brain stem. This is brain stem. In both of them, what you can see, there is some same pathology in both of them. Name the disease. Name the disease. Write down in the chat box. Spotter. It is a spotter. Nothing is given. If you ask me the clue, I will give you the clues. Patel, you are absolutely right. It is a good spotter. Clue ki zarurat nahi hai. If you want the clue, okay, patient is having a skin lesion also, a black color skin lesion. Now give me the diagnosis. Patient is having sole pe skin lesion. Patient is having a lesion on the sole, black color lesion on the foot, on the sole of the foot. And apart from it, this is the brain of the same patient. Yes, it is black, dark color. Patel, yes. Dark black color lesions you can see here. You can see here. You can see here. So multiple dark black color lesions in the brain. One here, one here. So I can find out 5 or 6. Dark black color lesions in brain, they are multiple. They are multiple, they are not single, so something metastatic is there. So metastatic, which tumor? Black color का tumor कौन सा होता है? I have given you a clue also. Patient is having sole पे, the same black color lesion in the sole also. So it is melanoma. Melanoma goes in the brain as metastasis. What was the sequence in brain metastasis? I told you, most common brain में mets lung के जाते हैं, followed by breast, followed by melanoma. So melanoma is the third in number, but it goes in brain most commonly. So patient is having patient के sole पे, पैर में, foot में, patient को sole पे, there is a black color lesion. The same black color lesions are present in the brain also. So it is metastatic melanoma. Give me a thumbs up. Give me a thumbs up. Now that is the level 1. That was a baby question which I have asked and only Patel have answered it correctly. Why others are not trying? I'm not happy with you, with the others. Why you are not trying? At least try, no? It's a typical diagram. Black color image, a black color lesion in the brain. What it else can be? Black color का और क्या होगा brain में? Multiple myeloma के अलावा it has to be melanoma, not myeloma, melanoma. It has to be melanoma. It is metastatic melanoma. It is metastatic melanoma. It is malignant metastatic melanoma, and it is going to the brain as metastasizing. Give me a thumbs up. Give me a thumbs up. Now some questions from MGT, then from FGT, then from general pathology. I will be a little bit faster. Done. So MGT, typical spotter. Look at the image. This is a testicular tumor. At 36, okay, age is important. Young patient, dragging sensation in the scrotum, having a left testis mass. This is the testes. This is the left testes, you can see, entire left testes. So this is the mass inside the testes, and this is the normal testes, which is shifted at the periphery. Diagnosis. Diagnosis. Since the patient is young, it has to be a germ cell tumor. So which germ cell tumor it is? There are 6 germ cell tumors. The mnemonic is YESPCT. Yes, PCT. What is the full form? It is yolk sac, embryoma, seminoma, polyembryoma, choriocarcinoma, and teratoma. So which one it is? Now I've given many clues. Come on, Patel. Yes, you are right. Anyone else? What it is? Okay, look at the gross. Look at the gross. The tumor is homogeneous. The tumor is lobated. Lobules are there. Lobules. Can you see? So typical yellowish tumor in the testes, replacing the testes at the periphery and covering the entire testes. So involving yellowish tumor, involving entire testes, and the tumor is lobulated. So typical only one word diagnosis. It is a gross appearance of seminoma. Please learn. It is a seminoma. It is a spotter. Come on. अगर सेमिनोमा नहीं पहचान पाए तो क्या पहचान पाओगे? It is a seminoma. It is a spotter. You have to identify it. Looking at the gross, oh, it is a testis. It is seminoma. It has multiple lobules. It is yellowish. It is homogeneous. It has to be seminomas. Without reading question, you should tell the answer. It is seminoma. Okay, if you can't identify it, you have clues in the question. The patient is young. It is a testicular tumor. Okay, वो भी बताने की जरूरत नहीं है. दिख रहा है ना? This is the spermatic cord. So spermatic cord से क्या टेस्ट होगा? ये टेस्टिस ही होगी ना? और क्या होगा? Okay, नहीं भी पता तो it is given in the question. It is left testis. So 2 clues are there. Young patient, left testis mass. Only 2 clues. So the diagnosis is here seminoma. Now the second level question. This was the first level question. Diagnosis. Second level question. Tell me the paraneoplastic syndrome associated with it. Tell me one paraneoplastic syndrome associated with seminoma. Third level question. What is the risk factor for this neoplasm? Risk factor. Biggest risk factor for this neoplasm. First identify it. Then tell me the paraneoplastic syndrome and tell me the risk factor for it. Who will tell me? Patel? Khushi? Yes. Anyone else? Anyone else? Says yes, it is seminoma because I have told you it is a lobulated mass. Tan color, yellowish, lobulated, homogeneous in appearance. Because of elevated HCG level, patient can have gynecomastia. It is a male patient now. In males, breasts are small in size. They are not enlarged. They are rudimentary. But this tumor secrete beta HCG in the blood, and this beta HCG, after going in the blood, it will go to the breast of the patient and breast will be enlarged. So such males have enlarged breast like females, and the disease is known as gynecomastia. So this gynecomastia is acting as a paraneoplastic syndrome of this. Give me a thumbs up. Everyone give me a thumbs up. Have you got it? Have you got it? That is the thing. And third thing, cryptorchidism is one of the main risk factors. You know cryptorchidism. So testes, this is scrotum. This is abdominal cavity. This is abdominal cavity. This is abdominal cavity, and this is the scrotal sac. This is the scrotal sac. So both the testes lie in the scrotum outside the body, but they are not developed in the scrotum. They are developed in the posterior abdominal wall, retroperitoneally here. And slowly and gradually they descend, and they come in the scrotum. And the path is followed by a ligament known as gubernaculum. You know this. This happens normally during gestation, during 9-month gestation, and at typically 9 months it happens that both the testes lie in the scrotum. If the male boy is born prematurely before 9 months, the scrotum is empty and testes yet not arrived in the scrotum. It is present in the abdomen. So this is known as cryptorchidism. Inability, failure of testes to arise into the scrotum. So this testes, which is present intra-abdominally, it is having high risk of seminoma. High risk. That's why surgery has to be done. So for this correction, we have to take the testes out and put it into the scrotum. The surgery is known as orchiopexy. Now, देखो कितने सारे questions we can frame on the same image. Image will remain same. I will change the question. Simplest question, diagnosis. That is the most simplest question. Simplest question. So simple. अगर diagnosis बन गया तो बाकी questions you can answer. अगर diagnosis ही नहीं बना तो बाकी कैसे answer करोगे? Second question, paraneoplastic syndrome. Third question, risk factors. Other also I can frame. What is the mutation? Name the mutation of this tumor. So first identify the tumor. Tell me the mutation. The name of the mutation is KIT and OCT. OCT and KIT is the name of the gene which is mutated for seminoma. Give me a thumbs up. So come on. So you should have an approach. You should not learn the image. Okay, I will share the PDF which contains 500 images with the diagnosis. But question will not come on diagnosis. It is not necessary. Image will be given and diagnosis is asked. Related to that diagnosis, anything can be asked. Now, so this image, I will ask the mutation of this. So first make the diagnosis, then tell me the mutation. Now, if you know the seminoma, you must know what is the mutation of seminoma. So all topics you should study in depth. You should know theory also. It is not the thing image देखिए होगे seminoma हो गया आगे बढ़ो. But seminoma क्या है, क्यों है, कैसा है, कहाँ है, उसमें क्या क्या होता है, treatment क्या होता है, पूरा पढ़ो ना. So question can come on anything. Have you got it? That is the approach. That is the approach. Have you got it? This is the next question. in front of you. Again, look at the image. Again, testicular tumor, young patient. Two clues are given. Testicular tumor, young patient. Image is given to you. So is it seminoma? Is it teratoma? Is it embryonal carcinoma? Is it York sac tumor? I'm launching the poll. Mark it. Whatever you think, mark it. At least participate in the poll. Everyone participate in the poll. At least give a chance. ना क्या है ये? तुम्हें देख के क्या लगता है? What it is? Okay. Chet, Patel, and Kiran are first to answer it correctly, and most of you are right. It is a histological diagram of microscopy of seminoma. That was gross. That is microscopy. Seminoma is that way important ना कि इस पे gross पे भी question आ सकता है, microscopy पे भी आ सकता है. You should know both things of the seminoma. What is the hallmark in this image? There is a hallmark in this image. Okay, you can see the tumor cells are arranged. This is the tumor cell. These all are also tumor cells. These are tumor cells. These are tumor cells. These are. So tumor cells are arranged in multiple nest. Now let me zoom it out. Each tumor cell is large with a central nucleus and a nucleoli, and the cytoplasm is clear. What I have said, tumor cell is circular. It is large with a central nucleus with a prominent nucleoli, and the cytoplasm is clear. Now I will zoom it out and see these features. Okay, see any tumor cell of your choice. So this is a tumor cell. See, it is a tumor cell. It is the cytoplasm is clear. This is the nucleus and this is the nucleoli. In all tumor cells, you will find the same history. Give me a thumbs up. That is a typical thing. One more typical thing. The nest, multiple nests are separated from each other by fibrous stroma. So this is the fibrous stroma. This is the fibrous stroma separating multiple nests from each other. There is a hallmark. The stroma contains lymphocytes. So these are the lymphocytes present in the stroma. That is the hallmark of this tumor. No other tumor has stromal lymphocytic infiltrate. See these cells. Can you see these cells inside the stroma? These are not tumor cells. These are lymphocytes. Give me a thumbs up. So lymphocytic infiltrate in the stroma is a hallmark of seminoma. Now look at the image. What you can see? You can find the tumor cells. They are arranged in nest. 1 nest, 2 nest, 3 nest, 4 nest, 5 nest. Nests are separated from each other by stroma. Stroma contains lymphocytes. Tumor cells are large. They contain central nucleus with a prominent nucleoli, and cytoplasm is clear. That is the description of seminoma. That is best fitting here. So correct answer here is seminoma. Teratoma में cartilage के बिना image नहीं होगी. You will get a cartilage in the image or bone in the image or hairs in the image. That will be teratoma का भी question है मेरे पास आगे. In the end वो आएगा अगर time बचा तो. Done. Embryonal carcinoma. York sac में you will find a Schiller dual body. What is Schiller dual body? Center में एक blood vessel होगा. There will be a blood vessel in the center, and tumor cells are arranged in the form of papillary projections around that blood vessel. Tumor cells are arranged in the form of papillary projections around that blood vessel. This body is known as Schiller dual body. That is the hallmark of York sac. ऐसा कुछ नहीं दिख रहा यहाँ. So it is not York sac. It is not teratoma. It is not embryonal. तुम्हारे syllabus में नहीं है. Microscopy don't learn. But seminoma. It is fitting here. Give me a thumbs up. Everyone give me that. You should rule out others also. अब others का भी आना चाहिए ना image. हो सकता है image change कर दें. Option यही रखें, question यही रखें, image change कर दें. So you should know image of teratoma also. You should know image of York sac also. York sac में typical Schiller dual होता है. उस पे question आ सकता है. Teratoma में typical cartilage, hairs, bone सब दिखेगा. उस पे भी question आ सकता है. Seminoma में typical lymphocytic infiltrate in the stroma होता है. उस पे भी question आ सकता है. तो whatever images which are having some pathognomonic feature ना उस पे IBQ आ सकता है. So you should have a judgment किस पे IBQ आ सकता है किस पे नहीं. Embryonal carcinoma पे कभी IBQ नहीं आएगा. उसमें कुछ भी speciality नहीं है identify करने के लिए. Give me a thumbs up. Give me a thumbs up. So this is, so you know the classification. I'm skipping it. Classification of testicular tumors. I have told you the mnemonic also. I'm skipping this portion. The theory. Coming on the next question. Next question in front of you. Based on Doppler. Okay. I will explain you the question. There is a newborn boy. As soon as he is born, he's a boy. He's not a girl. He's a boy. Newborn boy is born. He's poorly feeding. He's crying. He's irritable. He's poorly feeding. And he's born just now. We have just examined the whole body of the boy. The pediatrician has examined. And he found scrotal skin of the boy is fixed with a hard scrotal mass. So newborn boy having hard scrotal mass, and the scrotal skin is fixed that mass. He's a newborn. He's 1 day old. 1 day old. You have immediately done a USG. You have done an ultrasound of the scrotum of the boy. You have done the Doppler. You have seen 2 Dopplers here. You can see 2 Dopplers. Above Doppler is normal. You can see this one is normal. For comparison, it is given. And this one is the Doppler of the boy, the newborn boy of the patient, Compare the 2 Dopplers and tell me what is the problem with the boy. What is the problem? What is the abnormality in the boy? So what we see in Doppler, you should know Doppler में हम देखते क्या हैं? In Doppler, we see the blood flow. blood flow of the arteries, blood flow of the veins. So especially we see the blood flow of the veins. So in veins, blood is flowing as systole. When the heart is doing systole, more blood is coming. When heart is doing, left ventricle is doing diastole, less blood is coming. So all the time, this is a vein. The vein contains the blood all the time. During systole, more blood comes. During diastole, less blood comes. So there is always a pulsation. No? We can feel the pulsation here in our arteries. In veins also, it is pulsatile flow. So you can see this is the flow. This is the flow in a vein or an artery. So this is normal. You can see increase, decrease, increase, decrease, increase, decrease, increase, decrease. But it is never zero. Increase, decrease. So during systole, it is increasing. Diastole, it is decreasing. Again during systole. So it is normal flow. It is normal flow. Not only of scrotal artery, testicular artery. It is of any artery, any vein. See here, the blood flow is zero. During systole and diastole, you can't find any change. It is zero. So there is no pulsatility in the testicular artery and testicular vein in Doppler. What is the diagnosis? What is the diagnosis? Chet Patel, you are right. Chet is right. Chet has given the diagnosis. Vikram, you are also right. It is torsion testes. So the boy is having torsion testes. You know what is torsion testes? The testes got twisted on the spermatic cord. Can you see here? See here in the diagram. So see this testes. It is twisted on the spermatic cord. So this testes is twisted. So the spermatic cord, this is the spermatic cord and this is the testes. Now spermatic cord contains artery also. This is artery and it contains vein also. This is vein, just for suppose. This is artery, this is vein. Both are present inside the spermatic cord. So when this testes undergo twisting. So artery has thick wall, vein has thin wall. So due to twisting, vein will be obstructed, but artery will not obstruct it. Vein will be obstructed, artery will not obstruct it because it is having a thick wall. So blood is coming inside the testes, but it is not going out. It is not going on because vein is obstructed. So there is swelling in the testes. So all the blood get accumulated here. The impure blood get accumulated here. Testes swell up. It is severe edema is there. Highly painful condition is there. Blood is unable to leave the testes. And because of impure blood, it starts necrosis of the testes. The whole testes undergo like this, necrotic within few hours. Within few hours, if you don't operate and like untwist it, वापस operate, you have to open the scrotum immediately and untwist it. And again, you have to do the suturing. It is a simple surgery. Open the scrotum, untwist the testes, fix it, and do the sutures. So that, but you have to untwist it to again establish the blood flow. If you can't do it within few hours, the whole testes will be necrotic forever and it is irreversible. Once it is necrotic, you cannot bring it back. So it is an emergency surgery. Give me a thumbs up, that is torsion. Give me a thumbs up. So that is happening. Because of torsion, the blood flow is zero. You can see. So for torsion, Doppler is most important and IBQ can anytime come on this. So this is Doppler. How did this happen? I have told you due to the twisting of the testes. What is the time frame for preventing irreversible damage? So you have to do the surgery within 6 to 8 hours. Within next 6 to 8 hours, if you plan the surgery, it's okay. Otherwise, तुम बोलो नहीं अभी तो रात हो गई सुबह करवाएंगे. So patient is gone. Patient is not gone. The testes of that unilateral testes is gone. So young boy, so other testes will be. So patient can have oligospermia in future because only one testis is remaining. Now other testis is gone. Other testis is gone forever. So patient can be infertile. But other testes है तो infertile नहीं होगा. अगर both testes में है तो फिर infertility होगी. Give me a thumbs up. Give me a thumbs up. It is an emergency situation. It is an emergency situation. So for the parents, it is known to them. You have to consult them. No, it is emergency. You can't wait till morning. We have to operate right now. Within the next 6 to 8 hours, the testes will be gone forever, and child can be infertile in future after puberty. One of the testes out of the two will be gone, and if it is bilateral, both will be gone. So we have very less time. We have to do the surgery immediately. And if you are a surgeon, don't avoid such cases. If you are interacting any torsion case, operate immediately. Leave everything and first operate the patient. You can save the testes of the patient. Give me a thumbs up if you got it. Everyone give me a thumbs up. So coming on the, yeah. One more thing. So such patient is coming to you. It is not necessarily, it can occur in newborn only. It can occur in adults also. If any adult male is coming to you with severe pain in one of the testes. This is an adult male. And adult male is coming to you. You are a doctor. And the male is having severe unilateral pain in one of the testes. In one of the testes, severe pain. This is an adult in your OPD. So what two differences you will have in your mind? Severe acute orchitis or epididymitis. So what two differences you will have in your mind? Number one, he can have torsion की वजह से हो रहा है, or he can have orchitis. Orchitis, that is inflammation. Orchitis never occur alone. It occurs along with inflammation of the epididymis also. So orchoepididymitis, that is the second differential. So the treatment of two is entirely different. If it is torsion, emergency surgery, untwisted. And if it is orchitis, give antibiotic. No need to do surgery, give antibiotic. अब अगर torsion है और if you misdiagnosed और तुमने ऑर्काइटिस मान के एंटीबायोटिक दिया तो 6 आवर्स में टेस्टिस निपट जाएगी. और ऑर्काइटिस है, तुमने गलती से ऑपरेट कर लिया टॉर्शन समझ के, तो पेशेंट मारेगा कि मुझे क्यों ऑपरेट किया जबकि मुझे था भी नहीं ऑर्काइटिस. So both ways you have to make your diagnosis crystal clear. Patient is in front of you. What you will do, how you will make the diagnosis, whether it is torsion or whether it is orchitis. Treatment is different now. Torsion, it is surgical treatment. Orchitis, it is medical treatment, antibiotic. Give me a thumbs up. If you got the question, at least give me the thumbs up. If you got the question, have you got it? So how you will do the diagnosis? If you are in a hospital and USG machine is available in that hospital, emergency shift the patient to USG machine and ask the radiologist to do the Doppler, to do the USG of the scrotum. On Doppler, it will be clear. If it is torsion, blood flow is completely absent. If it is orchitis, blood flow is present. But the presentation is same. Both are present with severe unilateral testicular pain. So number one, but it is not necessary USG is available in all hospitals, or you are working in some periphery in a village. USG machine to puri gaon mein nahi hai. And if you shift the patient to the city or some other center, it will take 6 to 8 hours. And if it is torsion, tab tak to sab chala jayega. So you don't have time. You don't have nearby USG machine. What you will do at that situation? First day tum to ab kya karoge? What you will do? Imagine yourself in such condition. Now what you will do? So there are some clinical signs which separates the two, which distinguish the two. So the first sign is known as Prion sign. So what you have to do, on your palm, wear gloves, and on your palm just hold the scrotum upwards. Hold the scrotum upwards. So on moving the scrotum on the palm and hold it upwards, pain decreasing or increasing. See that is known as Prion sign. So in Prion sign, elevate the scrotum on the palm. So if it is increasing in pain, it is torsion. If it is decreasing in pain, it is orchitis. Have you got it? So increase pain, torsion. Decrease pain, orchitis. Elevate the scrotum on the palm by making the patient naked. Have you got it? So that is the thing. So if you are increasing it, torsion is more increasing. इसको तुम ऊपर elevate कर रहे हो, तो torsion और बढ़ रहा है. It is increasing. So it is increasing the pain. और orchitis में उसको relief मिलेगा and it is inflammation. Have you got it? That is the first sign. One more sign, Damprick sign, I have not put it. Okay. Next question is in front of you. Let me explain the question to you. A 10-year-old otherwise healthy boy. He's absolutely healthy. He doesn't have any problem. He's a kid. He's a 10-year-old boy. He is having only one testis in the scrotum. Other testis is not palpable in the scrotum. So parents got worried. You have only one testis. Where is your other testis? So they got the boy to you. You are a doctor. And after surgery, this is the two testes of the boy. Which one is abnormal? Which is normal? Which is the abnormal testes out of the two? Look at the color. Look at the size. Tell me which is abnormal testes. And where was the abnormal testes located in the body? It was, of course, not in scrotum. The scrotum contains only the one testis. Out of them, only one was present in scrotum. Where the other was present in the body? Where it was present. So, what is the condition known as? Yes, the small one. Yes, Khushi. The second one, Vikram. Yes, it is. This one is abnormal because it is small. It is atrophic testes. And this is normal. You have seen normal testes. It is brownish in color. See the parenchyma. It is having full blood flow. So it is normal testes. This is abnormal. What is the location of this testes? It was not in scrotum. So where was it in the boy's body? Where was it? It was present in abdomen. And the condition, yes, Vikram, Nimisha, it is cryptorchidism. So this is a typical case of cryptorchidism. Most of the parents diagnose it in early age of the boy. 5 to 10 years, they will diagnose that they palpate the scrotum of the boy and they found only one testis. So they will carry the boy to you that my boy is having only one testis or none of the testes in the scrotum. So where are the testes? Whether they are not developed. So you will say, no, it never happened. The testes are not developed at all. They are developed, but they are not present in scrotum. They are present somewhere else in the abdomen. So you will do a scan, you will do CT, MRI, whatever, and see where is the location of other testes or both the testes are in abdomen. So you will consult the patient, the parents, that your child is having cryptorchidism. So the testes, so operated within 1 hour, 1 year, first to second birthday, ke beech mein you have to operate it. Within first year, it comes in the scrotum spontaneously. If it is not coming spontaneously, you have to operate it. You can't wait beyond 2 years. If it is already diagnosed, don't wait beyond 2 years. Otherwise, as I have told you, it is present in the abdomen. The testis is not present in the scrotum. The scrotum contains only one testis. The other testis is present here in the abdomen. So if you operate it after 2 years, second year, and bring it back in the scrotum also, the risk of malignancy is same. The risk is already increased. The testes which is present in abdomen is 50 times more risk of developing seminoma as compared to the testes which is present in scrotum. So the abdominal testes is more risk, 50 times more risk. So if you take from here and keep it here in the scrotum, again the risk is still 50 times. If you operate it after 2 years, the surgery is known as orchiopexy. Give me a thumbs up. What will happen to this boy after puberty if parents are not operating the child? So one of the testes will remain in abdomen only, other testes in scrotum. What will happen to the boy after puberty? Whether he will be infertile or sterile. Whether he will be infertile or sterile. So he will not be infertile, but he will be sterile. You know the difference between the two. Yes. So this is known as cryptorchidism. The second testis, smaller one, is abnormal. It can be anywhere in the abdomen, from the lower abdominal cavity to the inguinal canal. It is present in the abdomen. It is absent in scrotum, and patient will have low sperm count. The fertility is reduced, but it's still fertility is possible. So infertile nahi hai, but sterile patient can be done, and there is high risk of developing seminoma. Which testicular carcinoma? Seminoma. Give me a thumbs up. Everyone give me a thumbs up. So you know what is cryptorchidism? It is partial. It is complete or partial failure of abdominal testes to descend into the scrotum. So this is the normal position of the testes, and here it is developed. So normally it descends down. If it doesn't descend down, remain there only, or आगे आके रास्ते में कहीं रुक गई. So it is known as cryptorchidism. It is known as cryptorchidism. Next question in front of you. Next question in front of you. Read the question. Identify the organ. Identify the organ. It is prostate. Now tell me the diagnosis. It is prostate. 81-year-old male, prostate biopsy given to you. 81-year-old male, prostate biopsy. Yes, Vikram, you are right. So only this much history is required. If you know the organ now, looking at the image, you should tell the diagnosis. So दिमाग में होना चाहिए testes में क्या क्या image आ सकती है. Seminoma आ सकता है testes में, teratoma आ सकता है testes में cryptorchidism आ सकता है, testes में torsion आ सकता है. तो इन सब की image clear होनी चाहिए. अब organ testes है तो इन सब में से क्या है? प्रोस्टेट है तो प्रोस्टेट में दो ही क्वेश्चन आएंगे, या तो बीपीएच पे आएगा या तो कार्सिनोमा पे आएगा. यू शुड नो इमेज ऑफ बोथ. सो प्रोस्टेट आइडेंटिफाई दोनों में से क्या है. दो ही ऑप्शन है तुम्हारे पास, आइदर बीपीएच और प्रोस्टेट कार्सिनोमा. और तीसरी चीज होती क्या है प्रोस्टेट में दो ही चीजें होती हैं. यू शुड नो डिफरेंशियल डायग्नोसिस. दिस इज नोन एज डिफरेंशियल. दिस इज द अप्रोच. I'm preparing you not only for your exams, your FMGE exam, INICT exams are in front of you. I'm not preparing you only for, after clearing the exams, of course, you will do your post-graduation and you will practice in your society. So when you will practice now, it is not the thing the patient तुम्हारे पास आके he will say the diagnosis, doctor, I am having BPH, give me the treatment. No, you have to make the diagnosis. So patient will tell you the complaint. Patient will tell you I am having increased frequency of irritation and uritation, more hesitation in urination, and he's an old male. You have done the prostate biopsy. This is the biopsy. So it is typical. What is the diagnosis? It is BPH. So in BPH, how I have, is it a premalignant condition? No, it is benign. The full form is benign prostatic hyperplasia, benign prostatic hypertrophy, BPH. And what is PSA level in this patient? PSA is a tumor marker. It is elevated. PSA is elevated in both BPH also, carcinoma also. Carcinoma it is more elevated, but in BPH also it is elevated. Give me a thumbs up. Give me a thumbs up. So that is the thing. That is the thing. So this is the diagram, typical image of a BPH. Okay, and see this image also. Then I will explain you both. This is a typical, again the same question. 80-year-old male and same complaints, having hesitation in urine, problem in urination, and PSA is elevated, and this is prostate biopsy. It is carcinoma. It is carcinoma. So what is the difference between this image and this image? How you identify whether that was BPH and this is carcinoma? Same age, same question, same PSA level. Everything else is same. Only image is different. Only image is different. So there are two things in the prostate. Okay, I have not put that explanation. Okay, so I will explain you in this image only. मुझे लगा मैंने explanation डाला है. Anyways, so in BPH, you know, in prostate, there is background stroma and there are glands. The glands are small circular glands are present, and background stroma is also present. So in BPH, what is happening? Both will do hyperplasia. Glands also increase in size, stroma also increase in size. So there is hypertrophy and hyperplasia of both things. So when glands increase in size now, their lumen increases, and they will, you know, this is known as papillary enfoldings aa jayenge, because they increase in size. Small thi to they were circular, but when they increase in size, they will have papillary enfoldings, and they will do more secretion. The secretion is known as corpora amyloidacea, and that will be collected in the center. So that is BPH. You can see the typical image here. In the BPH, you can see the papillary enfoldings. Papillary enfolding is important here. See, appreciate the papillary enfoldings. Appreciate the papillary enfoldings here. Please, everyone, papillary enfoldings. And see the corpora amylaceae in the lumen of these glands. That is a typical finding of BPH. And the background stroma is also increased. That is BPH. That is BPH. In carcinoma, what will happen now? These glands will not increase in size. They will remain small only. They will be, instead of double layered, they will become single layered. But the cells of them, just lining the gland, they will become enlarged in size. The cells will become hyperchromatic, nucleus is hyperchromatic, high ANSI ratio, but the size of glands remains small only. So see the second diagram. Okay, let me show you this one. This one. So can you see a gland? The gland is still small in size, this one, but the cells lining the gland, see this cell, this cell, this cell. Can you see? This is the mitosis, mitotic cell. So you can see the mitotic, you can see prominent nucleoli inside the cell. You can see mitosis inside the cell. You can see high ANSI ratio inside the cell. These all are malignant cells. So it is cancer. Everyone give me a thumbs up. Everyone give me a thumbs up. So my time is over. I have to stop here. So I have done with MGT also. One more question. Teratoma ka mujhe dikhana tha. One more important image I want to show you. Okay, this is penile cancer, pannus cancer, squamous cell carcinoma in the pannus. What is this? This is pannus. This is pannus. What is the abnormality in the pannus? One word, spotted. What is the abnormality? See the location of urethra. This is catheter inside the urethra. See the location of the urethra. Urethra should be at the center of the pannus. It is not at the center. It is on the ventral surface of the pannus. Yes, Vikram, it is hypospadiasis. It is hypospadiasis. So urethra present on the ventral surface, it is hypospadiasis. If urethra is not present at the center and it is present on dorsal surface, it is known as epispadiasis. So question hypo पे भी आ सकता है, epi पे भी आ सकता है. मैंने ये hypo पे लगाया है. You know now, you know now. This is ventral surface, this is dorsal surface of the testes. Yes or no? Give me a thumbs up. So that is the thing. So if it is in the center, urethra, it is normal. If it is on ventral surface, it is hypospadiasis. It is on dorsal surface, it is known as epispadiasis. Give me a thumbs up. इस पे भी image based question आ सकते हैं. Give me a thumbs up. So hypo epispadiasis हो गया, pannus का carcinoma हो गया. अब time नहीं है बताने का. Actually, last question. Okay, give me one more minute. I will come on it. This one, yes, this one. Spotter diagnosis. It is a tumor. It can be testicular tumor or ovarian tumor. Doesn't matter. It occurs in both. Males also, females also. Testes में भी होता है, ovary में भी होता है. You can see hairs inside the tumor. You can see teeth inside the tumor. Inside this tumor, hairs, teeth. You can see bone. You can see gelatinous cartilage. So it is nothing else than teratoma. Teratoma person testes also, ovary also. Question कुछ भी हो मुझे फर्क ही नहीं पड़ता है. ये male है कि female, I don't matter. It doesn't matter for me. It is a young person. Young person, male है या female है, teratoma तो दोनों में होता है. Testes है, ovary, it doesn't matter for me. Looking at the diagnosis, it is a spotter. You don't tell me anything. It is teratoma. It is teratoma. That is the thing. So okay. Anyways, few images, 10-15 images or more, but the time is limited. So you read by your own. I'm providing you the notes. You can download the notes. So I'm ending this lecture. So I'm having next lecture, but for plus subscribers after 15 minutes at 4:30. So if anyone of you is plus subscriber, you can join me from 4:30 to 6:30 onwards. We have plus class there. And for the pre-subscribers, we have lecture not tomorrow, a day after tomorrow from morning 9 to 12:30 as usual. 9 to 12:30, 3-hour lecture we will be having from day after tomorrow. That is from Friday. That is from Saturday. So we will continue the series. So for pre-subscribers. Okay, see you. Bye-bye. I'm ending this lecture.